like tells you deliver or not, shock advised or not advised. Okay, let's find out when it's advised and when not, because in hospital we decide when to deliver shock. Okay, not all ribs are shockable. Okay, let's find out what is shockable rib. Okay. I'll draw here some ribs, and after you tell me when to deliver shock. And here, all of the cases, we have cardiac arrest. Okay. We start with it's possible like that. It's black picture. Sometimes we have like this rate. Sometimes we have just a line. Okay. Sometimes we have some agonal rate. Okay. And sometimes we have like that, some agonal array. Okay. And all of them has names. Wait, I'll draw here from the beginning to be more visible.
Better, thank you.
Okay, what do you think? These all cases are cardiac arrest. Okay, there is not any pulse. When you check patient, when you do assessment, chest, pulse, no pulse, and after you like add pads or monitor, and you see that rib. Okay, but what cases we are going to deliver shock? What do you think?
The third one.
Third one, this.
Yeah.
Wait, I'll give numbers here. That's 1, 2, 3, 4, 5. Okay.
Because we have isoelectrical lines, so we don't have electricity at all.
Okay. Where else? What do you think? Any opinions?
The fifth one, I think we should not give electrics because we have nerve QRS. That means that we have delays in the ventricles contraction. No, it's heavy ventricle contraction.
Okay. Just I'll give now names. What we call that rate. Okay. First, it's a ventricular fibrillation. Second one is what? Ventricular tachycardia. Okay, but pulseless, because I said that there is not pulse. Because ventricular tachycardia can be with pulse. That cases we do synchronized cardioversion. Okay, today we just discuss about unsynchronized cardioversions. Okay. That's like asystole. Third one is asystole. Fourth one is agonal rate. Okay.
What?
Agonal, agony. Okay. When there is just okay, waves, but there is not contraction. And the last, fifth, is PEA, pulseless electrical activity. Okay, it can be like without P wave, with P wave, looks like the patient has a pulse, but there is not. Okay, just activity. There is not any contractions. I would say that when we deliver shock, just these two cases. Not here, not third, not fourth, not fifth. Okay?
The first and the third one?
Yes, not third one.
Second.
First one,
Second.
ventricular fibrillation. Okay, itself device gives you hint, defibrillator. Okay, what to defibrillate if we don't have any fibrillation, if we don't have any activity. Okay,
But
just this device shuts down abnormal activity of the heart. Okay, and when we don't have any activity, make no sense you deliver or not. You can't deliver from outside any electricity to heart to like start work. Okay, just it's about to shut down all abnormal activities what heart has. Ventricular fibrillation and pulseless VT.
in
Only two shockable. Yes.
sorry,
Yes.
in cases of ventricular tachycardia, so we're already having like abnormal beating. So why we are giving the defibrillator?
Just to like regain a normal sinus rhythm, okay? Because it's not sinus, it comes from ventricles, okay? From ventricles we don't need it, okay? That's pulseless case. You say it's only in movies. I have no idea why they're doing that asystole line and they are delivering shock. Oh, there is nothing. Okay, let's increase. It's not like that, of course. In real cases, we deliver shock only to cases: ventricular fibrillation and VT, pulseless. Okay. Today we discuss unsynchronized. Unsynchronized means that when we just charge and deliver shock. Synchronized we do in tachycardia cases, also in VT cases when we have pulse, of course. When we deliver shock on QRS and we have to activate sync mode, and after we can deliver, okay? But from the beginning, let's discuss unsynchronized. Here, what we are going to do, we have cardiac arrest.
Cardioversion.
No, I'm not asking any like defibrillator. We have asystole, agonorrhea, and pulseless electrical activity. When you like tap on the chest, check the pulse, there is no pulse, you saw that there is asystole, what you're going to do?
CPR.
CPR, yes. What drugs? What drugs we have discussed about during CPR?
Epinephrine.
Epinephrine, yes. And when we have VT or ventricular fibrillation, we deliver amiodarone. You remember that?
Yeah.
Yeah.
We discussed about amiodarone. That cases, because it's arrhythmia. Arrhythmia cases we are trying to like first manage with defibrillator because patient is unstable, and after like giving drugs, amiodarone or lidocaine. After third shock we deliver amiodarone 300 milligrams. After like fifth shock 150. That's all. Keep in mind always, okay? Unsynchronized cardioversion. Cardioversion and defibrillation is the same name, okay? Don't confuse. Unsynchronized we do in pulseless cases, synchronized in pulse cases, okay? When patient has pulse. Only two shockable rhythms we have for unsynchronized cardioversion. It's about like ventricular fibrillation and ventricular tachycardia. Okay, remember VT, VF, VT, VF, VT pulseless, VF of course there is not pulse. You see, there is possible. Have you ever like seen like this rate?
It's like a flutter.
It's a VT type. It's we call it torsade de points.
Yeah.
Or
We have
torsade, yeah.
morphic and polymorphic.
Yes, exactly. That case is also management is the same. If you have pulse synchronized, no pulse unsynchronized. Okay, drugs are magnesium here, magnesium deficiency gives that, and also about amiodarone after. Okay, that's very important to remember because this now you decide when to deliver, not AD. You have not any AD in emergency, okay, in any ward. We have real defibrillators like this, okay. As I said, that's universal defibrillator, has ability to deliver shock, synchronized, unsynchronized, also can does pacing, okay, when we have bradycardia and unstable the patient, okay. Now, how we deliver shock, where we add these pads, okay, we have to know how to use it, okay. Why we do first lubrication? Lubrication must be done because it can burn skin, okay? And better conduction we need, because without any with dry pads you just burn the skin and maybe not good conduction. These defibrillators are two kind. There is a biphasic and monophasic. Usually hospitals last time has only biphasic, which are better because means what? When I deliver shock, returns to another pad. Okay. Where we add these pads? Here, like that?
No,
No. How? Where?
maybe because the charge should go to the heart.
One. You see, here is written always labels. You see, sternum and apex. Okay, sternum. We know that it's here, but we don't add here like here. Okay. Next one, apex. We have here, but we add here. Okay. Because there will be better conduction. Okay, we have to this deliver current through the heart. Okay, current to shut down this abnormal activity. Because when patient has fibrillation, okay, heart does like that fibrillation. Okay, muscles are doing like there is not contraction. Okay, and that's why we are trying to shut it down. 1, 2, okay? How to deliver shock? Very easy. For example, these pads has a charge button and we have shock buttons. When we charge, okay, just we push and release, and after we press both together, okay, to deliver shock. Now I'll show you. I'll induce now fibrillation. Fibrillation, ventricular.
I think it's because of heart axis, yeah?
Heart what?
Heart axis.
No, it's not about heart axis. Just we have to conduct the electricity through the chest and through the heart. Okay, we have here fibrillation. You see? That's fibrillation. Abnormal, some chaotic activity, okay? It's not regular. VT, I'll show you how it looks like VT, for example. VT, ventricular tachycardia. It looks like that. For example, it can be more wide complex, but more regular, and not any chaotic some activity, okay? It's more organized than fibrillation, okay? It can be, as I said, with pulse and without pulse. Let's start with fibrillation. Now I'll show you how it looks like dorsal dead points. You see? In that case, it's possible to have pulse, but most of what I've seen in my experience has not pulse. Okay, management is the same. We deliver shock, of course, unsynchronized when there is not pulse, and after we give magnesium and amiodarone. But if we have pulse, we do synchronized cardioversion. Okay, I have a question. What would happen if I deliver to someone or myself accidentally the shock?
Die.
Are you sure?
Yeah,
Why?
because we have electric in the, but the problem is
Wait.
mixed together.
If I'm lucky and someone is lucky whom I delivered shock, that's 50-50. Then why? Because synchronized cardioversion cases, patient has pulse.
Yeah.
And what you're saying means that when I deliver on the patient the shock with pulse, I would kill him. No. If you deliver on QRS, accidentally when I deliver shock on myself, maybe I am not like cautious and I'm touching the patient during the, that's why we say before we deliver clear. Clear means that patient is not clear or a surrounding. Clear means that we don't touch anything. Also not any bed, it can be wet, okay? That's right. If you deliver shock on healthy person, on QRS, not any problem, just burns, okay? And very like painful, of course. But if you deliver somewhere in middle on T wave during repolarization, okay, there is a cardiac arrest. That's why we have 50-50 chance. That's why I don't risk. Okay, that's very important. That does mean synchronized cardioversion. When we like switch on sync mode when we have pulse. So for example, VT patient, not pulseless, appears here like marks. I'll show you how it look like that. Okay, and when you push shock button, device waits. Okay, is waiting QRS, and after delivers shock. You just pushed and there is no shock, and after delivers. Okay, it's self device. Just you have to push. That's synchronized cardioversion. Okay. For example, here I did tapping, patient is unconscious, checking the pulse, I have 10 seconds, no any pulse. I like switch on, of course I can add pads on the patient. Of course, before we like have any device, we start CPR, not any questions, everything is the same. And now I have the device, okay? I have device and I'm adding these pads to see what rhythm I have. And what is there?
It's a it's VF.
Yes, ventricular fibrillation, same as you have there,
Yeah.
okay? But you see, these pads has the ability to check your ECG. ECG read, okay? Not ECG, it's not 12 lead, it's a second lead usually. I now place my hands and you can see my rhythm also, you see? Is anything?
Yeah,
Nothing?
it's empty.
Yeah.
That's nothing, but it's some.
Okay, artifacts, okay,
Yeah.
wait. Because my hands are not still. You see?
Yeah, it's a precardial.
That's my QRS, that's my rhythm, okay? And that's how we find out patient what rhythm. And now you decide deliver or not. Of course, when you saw that there is a fibrillation, we have to choose energy. Energy can be like changed from here. Biphasic defibrillators, we can start from 120, okay, and 25. And for example, for this device, recommended is 200 for adults. Okay, okay. Let's decrease because to be more safe. It's impossible to get any shock from the dummy because it's like rubber, okay, and it's silicone, and that's not possible. But still, we must be careful, okay. Now, what I'm doing, like I added, of course, lubrication must be done. Here, I'm watching. Oh, there is a fibrillation. I'm going to charge, okay. Charge button is the yellow. Press. Now it's charged, okay? Now I'm saying clear, loud, okay? Clear, and deliver shock. What happened? After I deliver shock.
Why it's isoelectrical?
A system.
Yeah.
Asystole. Most of cases we have asystole after that because heart needs time to regenerate again the pulse. Okay, that's why we are not waiting anything. After we deliver shock, we continue CPR. 5 cycles. Okay, again 5. After 2 minutes, after 5 cycles, I am checking again pulse and I'm checking again rate. Okay, if there is still asystole, just I continue. If there is fibrillation still, I will deliver shock, but after 5 cycles. Okay, it's not like you deliver shock and there is not any recovery and you deliver again. No, you delivered because like brain needs circulation. Okay, and after like delivering shock, if there is not any recovery improvement, okay, of course you have to intubate also the patient. You have to start like ventilation. Okay, you can start of course from the beginning of the ambu bag and after intubate the patient. Okay, as well as VT cases, if we don't have any pulse, we deliver shock. If we have pulse, we deliver synchronized shock. Synchronized shock, unfortunately, we can't do here, but looks like same, not any changes. Okay, just we have to activate sync mode. Here is the sync button, and when you activate sync mode, you have triangles on like QRSs. I'll show you now. You see, here is, for example, defibrillation shock detected, says like device, and convert to normal sinus rate. You see, after you can get sinus, first bradycardia from the beginning, and after you can get normal sinus rate. Okay, you have recovered. What vital sign you don't have? It's about respiratory rate. That's why we have to ventilate the patient. Okay, that's very important. I have very interesting, like real scenario when patient has like not VT but SVT. What is SVT?
Supraventricular.
Supraventricular tachycardia. What is the management for supraventricular tachycardia? For drug, what we do before drugs? What we are going to do? What do you think? Do we have any drugs for SVT? Or we just leave? Because SVT cases, pulse can reach 300. Any antiarrhythmic drug which is for SVT?
We should use amiodarone.
No. Amiodarone we can, but first line drug is not amiodarone.
Epinephrine.
No, you have
Patient has tachycardia. Why epinephrine?
Give us the first alphabet for the drug.
It's A. Atropine. No. Atropine increases the heart rate.
Adenosine.
Adenosine, yes, exactly. Before we give adenosine, I'll teach you very, very interesting stuff here about, have you ever heard about Valsalva manners?
Yeah.
What is Valsalva manners? You can use it in stable patients, okay? Of course, when I'm saying stable, unstable, it's about parameters, okay? I'll teach you how to find out patient is stable or not. First, when patient is stable, normal pressure patient has, normal respiration, conscious level is okay, and patient has not any chest pain, we have to try Valsalva manner. That's a modified Valsalva manner. Okay, we are giving a patient a syringe, okay, and we are asking to blow for 15 seconds, okay, and try to push plunger out. Of course, it's very hard, and after we elevate legs on 45 degree for 15 seconds, okay? And what happens? Why we do this? What do you think? What's the purpose of these manners?
So now the blood goes to the back to the heart.
And
To reduce the
increases vagal tone because we have here baroreceptors, okay? When we have high pressure, body itself tries to regulate and decreases the heart rate, okay? Vagal activity. There is also possible to press here, carotid massage we call it, okay? Carotid massage, and here, and we can also trigger baroreceptors and decrease the heart rate. But that valsalva nerves are very safe, of course, if patient stable. Normal pressure, conscious, not any chest pain, not any pulmonary edema, okay, everything is fine, maybe a bit low pressure, but bit low pressure always on high rate is possible because heart has no time to refill with the blood, okay, it's obvious. That's first in SVT cases, what we do. Before adenosine, after is adenosine, of course.
Valsamanover.
Valsalva,
Valsamanover for the before.
SVT.
Yeah, SVT.
Now I'll show you emergency cardioversion. It's about when patient has SVT and has, okay, wait, before I show you, I'll show you how it looks like cardioversion on this device. They have same device. You see, here is the patient with, as I remember, this patient has atrial fibrillation. Okay, they tried all the drugs, and last what we do is cardioversion. We have to sedate patient because patient is conscious. Okay, you see triangles up to QRSs.
Yeah.
Okay, that's a marking, sync mode activated, okay? And after the patient is ready, they deliver shock, okay?
Why they apply the pads like this?
You see that pads are more safe because you are far from the patient and you just deliver pads like this one, and this connected to the defibrillator, and you are doing from here, okay, you are far from the patient, but they placed here and here because patient is stable and you can do that, okay, because if you can to like elevate the patient, okay, but if the patient is not stable, here and here, of course, here and here is better because you see in the middle we have heart. Okay, let's see how looks like this. Okay, you are delivering the shock. Okay, here is the sync button. You see that's a green light. It means that it activated and appeared triangles up to like QRSs. Church, they are delivering 200 joules. Okay, same defibrillator they have. They're waiting for sedation, of course. Oxygen is given because during sedation, breath is not so good. Okay, delivered shock. And after, you see, P wave, P wave, P wave, P wave, P wave. Now we have and regular. We have sinus, okay? From the beginning, it was not sinus, right? Here it is, you see?
No PV.
Yes, not any P waves and irregular. Okay, that's a case when we, for example, you have 48 hours to, like, for example, manage atrial fibrillation. Here you have patient in emergency with atrial fibrillation. Maybe tachysystole patient has, okay, maybe 140. Of course, you are not going to give any adenosine. Treatment is amiodarone, of course. And 48 hours, you are going to manage with like electrolytes, you check everything, give amiodarone, like you can reach to 1.2 gram in like 24 hours, and if there is not any improvement, last what you do is cardioversion. Synchronized, of course, patient has pulse. But when you have patient with atrial fibrillation, or VT, or SVT, with pulse, I mean, and patient has unstable permits, okay? Low shock, for example. Shock. How would you like find out a patient has a shock or not? First, what's the signs of shock? Because just low pressure is not the shock. You can have any time, for example, low pressure. For example, I keep 120, and if my pressure becomes 110 or 100, it's not shock, it's a hypotension. But shock has the signs. What signs we have for shock? What you think? You see the patient in shock. From the start with inspection, from the skin, what looks like?
Sweating,
Sweating, okay. Color,
pale color,
what color?
pale.
Pale, maybe cyanotic,
Yeah.
okay. Decreased conscious level, of course. Patient has respiration rate increased because compensatory, okay. Tachycardia patient has, okay. Now we speak about tachycardias, and for us interesting, patient has conscious level decreased or not, and shock signs has or not, sweating and like this stuff. What else? If patient has chest pain, unstable, because means that ischemia is going and we have to do something in short time, okay? We have no time for drugs, okay? And or when we have patient shock, of course, you can't give any amiodarone, because amiodarone decreases more the pulse, not pulse, as well as pulse, also pressure, okay? If you inject, okay, I have normal pressure. If you inject to me like amiodarone, I will have hypotension, okay? That's like no side effect of this drug, of course, because it has beta-blocker activity. Also, when patient has pulmonary edema, what do you think? How to find out patient has pulmonary edema or not?
Chest X-ray.
Chest?
X-ray.
With physical examination before you do chest X-ray, because patient here have unstable
Percussion.
percussion, and what you hear with percussion?
Should be dullness.
Dullness we have when we have effusion, not edema. Auscultation, when we do, what you hear when you have pulmonary edema? What sounds?
Crackles.
Yes, crackles. Where else we hear crackles? Differential diagnosis. You have patient, dyspnea, you auscultate and patient has crackles. Not only pulmonary edema gives you crackles.
Pneumonia.
Pneumonia, yes. How to find out is pneumonia or pulmonary edema? Pulmonary edema cases, it's symmetric, okay?
Oh yeah.
Symmetric. And pneumonia cases, maybe right side, left side, okay?
Asymmetric.
Symmetric, it can reach to the top, okay? To the apex of the lungs. When it's severe pulmonary, you have no time to deliver any drugs. You have to deliver shock. You see, what does mean? Stable and unstable, okay? Remember that unstable patient has these signs, okay? Now, I'll show you now how they deliver shock. It's a very good example. It's a real footage, of course, of the patient which has SVT, okay? That patient. Okay, when we look at this patient before, like with inspection, like habitus, we can find out what is this patient's lifestyle itself. Okay, let's see first the monitor. Okay, monitor. We have to check. And you tell me this patient is stable or not. What do you think? Let's check all vitals.
The heart rate is very, very high.
Heart rate is very, very high. What about rhythm? Is it regular? Looks like regular or not? Of course, we don't watch only monitor, and we don't decide anything with monitor. We have to do 12 lead ECG, and on paper we say it. Okay, but looks like regular or not? Yes.
Yes, regular.
Regular. Okay. What about itself QRS? Is it wide or narrow?
QRS.
Yes, QRS complexes.
Narrow.
Narrow.
No, it's wide.
For me, it looks like white, but she's right. It's a narrow. When we see on tablet ECG, it's a narrow. If it was white complex, we would say it's not SVT. It's a VT. Okay. When it's wide complex tachycardia, it's a VT. But here is a narrow complex tachycardia. Why the patient has like this strange ECG? Because the patient maybe in history had MI or something, and QRS was not narrow, or block patient has, looks like that, okay? But we will see it on tablet ECG. Here is also shown. As I said, SVT can reach to very, as well as VT, of course, till to 300, okay? And we have here SpO2. Is it okay?
Okay.
It's okay, yeah.
Okay, up to 95, we say it's okay. 25, what is it?
It's up. It's for the rate.
Respiratory
rate. It's up,
Respiration
yeah.
rate. It's increased, of
Yeah.
course, obvious.
After
but-
20.
And let's look at pressure.
Speak low.
Okay, we have low pressure, and what is the third number? What is it
Heart
called?
rate. Heart
No,
rate.
The heart rate we have
Heart rate
here.
is up.
It's pulse.
No. It's a mean arterial pressure. Okay? It's this has formula for that. Twice diastole,
Yeah, please.
like plus systole divided on
Divide.
3, you get mean arterial map. Okay, map. And map we need for intracranial pressure formulas to calculate patient has perfusion pressure of the brain. Okay. Okay, it's not for our topic, but we have to know about that. The third number is mean arterial pressure. All devices has this ability. As we see from the beginning, okay, this patient, okay, when came to hospital had like 94, 92, 90, 88, 105 on 45. We have low pressure, okay. Usually that age patients don't have like so low pressure, but what do you think? This patient is unstable or stable? You've seen this patient already. He was sitting position, can talk, okay. And what do you think? Patient has like...
So unstable.
It's stable.
It's
yes.
stable or unstable?
Stable. Because this respiration rate means nothing, okay? Because it's always a bit increased. Because patient, just imagine this rate, okay? Very high. It's anxiety a bit, okay? But that's what why I explained the report, because low pressure not always is a shock. Okay, shock has a signs. Patient is conscious, sitting position. Okay, no any sweating, can talk, nothing. Okay, not any chest pain, of course. Now let's continue and let's discuss about this patient. This patient looks like, you tell me. You see so many wires. There is pads already, then preparing for delivering shock. There is ECG cables, there is monitor cables, okay? Okay, let's discuss a bit. Here we have for ECG, V1, V2, V3, V4, V5, V6, okay? Right, left. And here we have pads, adhesive pads for delivering like shock. They're going to do, of course, synchronize because patient is conscious and has pulse. And this is for monitoring, what we saw on that like kind of device, okay? That's very important.
Why the other bands is in the hand?
A pad is here, it's not, you see, here is the pad,
Okay.
like this, and this cuff for pressure,
Perfect.
yes. What do you think about this guy? What is his lifestyle?
Is homeless?
Homeless, okay. Homeless guys, what they like consume usually? Alcohol, okay.
Drugs?
Drugs, alcohol and drugs leads to what abnormalities to patients?
Cardiac arrest.
No, not from the beginning, before like cardiac arrest. They have like ischemic disease, of course. There is atherosclerotic problems. Of course, they have first electrolyte disturbances, okay? Electrolyte like potassium, magnesium, okay? It leads to arrhythmias, okay? You see here, in history, we have 4 days, okay, before this event, 4 episodes, and it was Valsalva relieved. He knows how to do this, Valsalva, or they did in hospital, okay? He is coming with in emergency. They are like giving syringe, okay, elevate the legs and relieve. SVT, just imagine. But today there was not any success. They tried Valsalva again. No success. After there is what drug?
Adenosine.
Adenosine. They gave adenosine 6, 6, 12. Okay, 6. First you give 6, after 12, and after you can repeat 12. Okay, I'm saying about milligrams. Okay, 6 milligram, 12 milligram, and 12 milligram. In European guidelines, you can give 6 milligram, 12 milligram, and 18 after. Okay, 3 times. And after is cardioversion, of course. If patient like still has this arrhythmia. That's why don't worry. All hospitals, all countries has all like
Guidelines.
its own guidelines and protocols. Okay, and you'll follow that. Okay, they tried Valsalva, they tried adenosine. Now they are going to deliver shock. Okay, synchronized with sync mode. They have same defibrillator as we have here. And also they are going to sedate the patient. But when we give any drug, remember always that we have to think about side effects of this drug. What do you think? What's the side effect of the sedative drugs, hypnotic drugs?
Sedative.
Yes.
Addiction.
No. Just
Decrease the
what?
respiratory.
The respiratory rate also decreases, tidal won't decrease, but what is the main?
Decrease the heart rate.
Not heart rate. If heart rate were what?
Respiratory rate.
Respiratory we said already. What else decreases?
Blood pressure.
Yes, blood pressure. And this patient already has low blood pressure. What to do? You can't deliver shock on like conscious patient. You have to sedate it, but you have already low pressure, okay? That drug, what you've seen, like this white non-transparent drug is a propofol, okay?
Yeah.
Which is hypnotic drug, and side effect is low pressure, of course. But we can do half doses. That's why you will find out what would happen here. They could not like sedate fully that patient because for 1 kilo is 10 milligrams propofol. Okay. For example, I'm like 80 kilo. I need like 80 milligrams like this propofol. But here they couldn't like give full doses. And let's see.
We've tried, Charlie, what have we done so far?
It's 6 and 12, and then we did 24 all the way.
No success, okay?
Alright, we're gonna send you back, okay? Now, this is gonna be a little uncomfortable, okay? That's nice with the bullet. The real with the bullet is it's gonna feel like somebody hit you in the chest with a baseball bat. Okay? And hopefully we won't have to do this more than once. Are you feeling?
Sync mode activated. Now let's see types of SVT, okay? For example, that's normal sinus rate, okay? When we have pulse from sinusoidal node, it's AV node, Hisi bundle. That's okay, normal. Atrial tachycardia, atrial fibrillation cases, we have from somewhere ectopy rib, okay? Some we are here, not from sinusoidal node. It can be regular and irregular. When we have entry tachycardia, okay, these are two kinds. Sometimes it's inside AV node we have this abnormality. There is a fast pulse phase, slow pulse phase, and that's abnormality. And when we have additional some way for conduction of impulses. For example, SA node like gave 2 days, and after AV node like return itself to AV node very quick before contraction. okay? And you see, it returns and it can reach very high rates, okay? That's why in that case, what we are going, why we give adenosine? Adenosine shuts down like this AV activity, AV nodal activity, because there is not, when you deliver AV like adenosine, I'll show you what would happen to the patient. Just you have temporary asystole, just P waves, because conduction is not from AV node to ventricles, okay? And they try, but still they have problem. Down the last, what we do is the shutdown with electricity, okay, this abnormal activity, and give a chance to reset normal rhythm with SA node with like AV conduction.
Yep, sorry. Put this up. Orange one. How are you feeling? I'll put this back on you here. Start it up, thank you. Okay? Okay. Alright, here it comes, sir.
You see, he could feel that it's painful, of course, but they couldn't sedate. Okay, let's look at monitor. What happened after they delivered shock? You see, monitor needs time to calculate the rate. Okay, it's decreased, of course, already. It was 255. It could decrease more. But what we see here, that patient's natural second lead rate is like a pattern of QRSs. Okay, there is not R wave. That's why it looked like so strange. Okay, this patient had previous MI, I think, because in second and third and AVF, we will see that there is not any R waves. There's a QS complexes, and it's a sign of that. But okay, P wave. Before QRS, it's like negative, but we have everywhere P waves. That's sinus rate now, okay? In SVT cases, you can't see any P wave. It's buried inside because it's an AV nodal activity, okay? And you can't see any P waves. Maybe it's negative or somewhere, but here we have sinus rate now. Patient has now normal, and you will see that pressure also improves after. Okay, and everything is okay, because now heart has time to refill with the blood again, okay? A normal like time, okay, for that.
You all right?
We didn't sedate him completely because of his low blood pressure.
Patient has oxygen, of course, because as you see, respiration rate not so good,
Arm is holding.
but it's why we choose that drug, because it's short acting. After 3-5 minutes, patient is awake, totally awake.
You doing all right?
You okay?
This habit, you see, patient is holding something in the head. This does usually alcoholic patients under sedation, okay, when they are not fully conscious. They always trying to take something and drink, okay?
Yeah.
That's a habit. You see, he's trying to like put this in mouth, okay? I used to work in ICU, and when I had alcoholic patients after like awakening, they always does that, okay? Sometimes they took some devices to like put in the mouth. It's like drinking, like.
At least. Yes, no, no, no. Orange right is also one.
Still trying to take time. And let's see on
You
ECG.
okay? Good.
Okay, that's like after delivering shock. Okay, very good example. What is patient's normal like ECG? Okay, it's after delivering shock. As I said, you see third, second AVF, which is inferior, which is right coronary artery. Patient probably had MI. That's why there is not any R wave. Here must be R waves, okay? It's a very small and like almost QS complexes we have, okay? Because there is nothing. And here, for example, after we see like these chest leads, for example, V1, V2, V3, V4, V4, V5, V6, there is R raise, but they raise late. It also signed the patient had previous MI, not acute, of course. Now, and everywhere we have P waves. You see, before QRSs we have P waves, P wave, P wave, everywhere. That's a sinus rate. Let's see what was before, okay?
Problem 6, okay?
That's
Make sure that he has me
great.
parked. You have to make sure that there's nothing.
You like the lights?
You gotta make sure it's not-
Rewind.
You gotta make sure, I mean, I'll use the drone.
I want to show you this SVT.
There's no. Make sure. Sorry about that, but problem 6, okay?
Here. Okay, look at that. So wide QRSs we have because it itself that leads patient had already problem. Okay, second, third, and AVF. Now on tachycardia looks like that. Okay, during tachycardia possible ischemia of course. As you see, we have here not so like a wide complex. It's a narrow. Okay, narrow. It's a narrow complex tachycardia. That's like SVT of course.
Make sure that he has me parked. You have to make sure that there's.
That's it. Now we will be fine. Just the patient needs recently stopped ethanol. When they stop taking ethanol, more complications are coming. Yes, seizures, arrhythmias, like okay, they feel pain, okay, and sometimes sweating, and many complications after by addiction, okay, when there is a abstinence of that drug, as well as alcohol on drugs. Here is alcohol is the reason.
So you move whatever you can.
Okay. Now that's what I wanted to show you about delivering shock when we have, for example, here it was pulse, and we are going to today practice on unsynchronized cardioversion when we deliver shock because we have no pulse. Okay, there is a ventricular fibrillation or VT. Okay, any pulseless cases when we have shockable read we deliver. We don't deliver shock on asystole, not any agonal read, not any pulseless electrical activity. Only two shockable read we have. Ventricular fibrillation, ventricular tachycardia, pulseless. Okay? With pulse, we deliver sync. Without pulse, no sync. Okay? Remember like that. It's very easy. Okay, let's do a big break, and after we start